Good afternoon, everybody, and welcome back. We hope you had a lovely lunch break and a good refreshment. We are back now for the radiotherapeutic management of primary colorectal cancer, and we are here with Dr. Kristopher Dennis, who is a radiation oncologist in the radiation medicine program at the Ottawa Hospital and also works alongside the University of Ottawa. Dr. Dennis completed medical school at the University of Western Ontario, residency training at the British Columbia Center Cancer Agency and the University of British Columbia, and fellowship training and graduate school work at Sunnybrook Health Science Center and the University of Toronto. Clinically in Ottawa, he leads his division's gastrointestinal and palliative disease site groups. And without further ado, I will pass it over to Dr. Kristopher Dennis. Thank you so much for being here with us today.
Thank you, Chris. I'm gonna share my screen here. And hopefully people can see slides. Could somebody just confirm? Great, thumbs up. Okay. Hello, everybody. Sorry to take you from your lunch break. But I'm very happy to be back with the group again this year. My email will be at the end. I think you've received a copy of the slides already, but if you'd like to contact me afterwards, please do so. I'm happy to chat offline about the material here or things in general. No conflicts. And by the end of today's talk, hopefully you'll get a little better understanding of what we mean when we say radiotherapy in the management of patients with cancer in general, not just colorectal cancer. Understand how we use it for primary colon cancers and rectal cancers for sure. Be able to describe to other people what's involved in radiotherapy planning and then the actual process of receiving it, and then get an idea for what patients experience. And I know there are some patients with us today, so I can be happy to be corrected at the end. This is the slide I put in to remind myself that I know what I'm talking about, but other people don't. I had this up on a screen with my little daughter during fellowship, and she said, "Daddy, look at that." And I was getting ready an answer with technical details boiled down, appropriate for a young kid, about what a radiation machine is. And she said, "Look, it's an armpit." So that's just my cue. What I see in my slides is not what everybody else sees. And so please pause and put up a hand or something like that. I'll ask others on the line to let me know if there are real-time questions that I can answer, because I don't think I'll reliably see the notifications. And so, yeah, as Chris said, I had a little roundabout way through my training through Canada at different spots, which was nice. Not let me see the country, let me meet my wife, and then also got a sense for how cancer systems operate in different provinces. And I've been here in Ottawa now for 13 or 14 years. And so right to it, when we talk about radiation, what is it? And so it's energy. I tell people it's X-rays, and it's just basically energy that can give something to the medium through which it's passing. And so you don't see it, you don't taste it, you don't hear it. You hear the machines and you can see the machines, but what we do is basically invisible, like an X-ray. That's more familiar to people colloquially. The different types of radiation that we talk about, though, is where it gets important. So the ionizing radiation that I use, this is particles or it's waves. And so the most common one that is used is photons. The other words are gamma rays or X-rays. But we also use particles, electrons and protons and neutrons. Non-ionizing radiation, that to which we're subjected all the time, is things like sunlight and microwaves and photocopiers and things. And so what's the difference? Well, it's not the amount of energy, it's how it's packaged. And so it's the size of the energy packets as they travel through the air. And so for ionizing radiation, the energy is concentrated in these small little areas, and that's what allows it to travel through the tumors and cause damage at the DNA there, compared to non-ionizing radiation, for example, heat, which is more generally distributed. And so the example that we learn as residents in radiation oncology is if you had the same amount of energy, 4 gray, this is the unit that we use, and you gave it to somebody, If it was the ionizing type that we use in treatment, 50% of the people that receive it would die. If it was non-ionizing radiation, like heat, it would only raise the body temperature of that person by a couple thousandths of a degree. So it's not the amount, it's the type. And so radiotherapy is using this sort of energy to kill cancer cells and shrink tumors. And when we talk about that type of radiation, the therapy, most of the time it's people receiving it after it's being delivered from outside the body, but it can also be delivered inside the body, brachytherapy, seeds or needles, and also systemic radiotherapy. So radioactive particles that are attached to different vectors that are injected into the bloodstream and can travel to different parts of the body that way. Or radiation just delivered on the body. So plaque you can sew in at the time of an operation inside the body or outside the body on the skin. Radiation, um, little, well, we'll call them seeds, but they give off radiation very locally. We do that in treatments like melanoma or skin cancers or spots within the gut and the liver if we're worried that some cancer is being left behind at the time of a resection. And so we prescribe radiation like people prescribe drugs. We have a dose, and the unit that we use is gray instead of milligrams, for example. And we would love to be able to just give all of the dose to kill the tumor at one time, but we can't because although we don't really care so much what happens to the tumor, we do care what happens to the tissues around it. So we have to break it up into smaller treatments or fractions that we call. So that's why some people will get treatments that last just 1 or 2 sessions, and others get treatments that last 3 or 4 weeks, sometimes 6 or 7 weeks. It has to do more with the good cells and the good tissues around the tumor rather than our desire to treat the tumor in a different way. And so our specialty, radiation oncology, is a small one compared to others. I'll tell patients when I meet them, or I try to remember, in some countries, you have one oncologist that will do things like chemotherapy and radiotherapy, but here the specialties are divided. And so that's why there are 2 appointments. And so for medical oncology, it's a little bit easier to set up if you have a pharmacy, if you have a lab and things like that, and a chair and an IV pole, you can sort of give chemotherapy wherever you like. With radiotherapy, though, the infrastructure needs are huge and enormous. And so there are only about between 40 and 45 centers in Canada that can give radiotherapy for patients with cancer. And we're all a close-knit community, the Canadian Association of Radiation Oncology. We meet every year. We learn from each other. We try to have some fun. We have our charity run. So that's a picture of us on the wharf in Halifax a few years ago. And we work very closely with our allied groups, our physicists and dosimetrists, our dietitians, nurses, pharmacists, and the radiation therapists chiefly. So lots of good collaboration between our groups. And so what do we do for patients with colorectal cancer? Most of the work has to do with patients with rectal cancer. And it's not because radiation doesn't work for colon cancers, but colons have a tendency, a lot of it, to move day to day. And it helps us with radiotherapy to have, pardon the term, but a target that will stay more or less in the same position day to day. There are some exceptions to that, which I'll touch on later. But in general, that is why that's the main reason we've treated more patients with rectal cancer over the years, because it stays in the same position within the pelvis compared to the colon, which is more mobile. And so with rectal cancer practice, most of the time we've been treating patients with T3 or T4 or node positive disease, so more advanced cancers. But there are a lot of new roles now for radiotherapy in the management of patients with early stage cancers. So ones that the surgeons don't necessarily need us to shrink or modify in some way before they attempt to remove them. But sometimes we're now thinking about radiation as an alternative to surgery for certain sorts of patients. For palliative intent treatments, and we'll talk about those later, any stage. There are, as I said, extensive and necessary collaborations that have to take place when it comes to managing patients with rectal cancer, and specifically, even with algorithms, even with shared practice models and guidelines and things like that, a lot of the times you can have a guess what your colleagues are going to say if you're the first person to meet a patient with rectal cancer. But it is always best to wait, if you can, for a surgeon a medical oncologist and a radiation oncologist who have all met the patient before sort of signing off on a treatment plan. Better outcomes happen, and there's certainly better cooperation. And it's just nice to have the message shared amongst the whole team. Um, it's becoming more and more important now because compared to even 10 years ago within my own practice, where we had a few options for patients with rectal cancer or ones that we would look to routinely, now there are so many different treatment pathways, and the algorithm has become far more daunting. And so getting everybody's input is even more important. Um, the good side about lots of options is we can personalize things to a better degree than we could before. The downside is it often takes a little bit longer to get to the sort of recommendation that we think is best for a patient, and then for them to decide if that's right for them or not. Multidisciplinary rounds, that's the answer that you say, well, everybody should be discussed in rounds. And it's true, it would be nice, but I could easily have myself losing a half a day a week just from rounds talk for shared patients and stuff like that, time when I could be seeing new patients and moving them through. And so in some centers, I think most patients with a locally advanced rectal cancer are discussed within a rounds. In bigger centers where the numbers are just too big, it's more the cases that are a little bit different from the norm, where the benefit of a full rounds multidisciplinary review is sought after. And so for these locally advanced rectal cancer treatments, you can give treatment before surgery. So we call that neoadjuvant treatment, or you can give treatment after surgery, and that's called adjuvant treatment. Sometimes it's radiation on its own, sometimes it's radiation with chemo at the same time. Sometimes you get both of those things given sequentially in various forms. Many trials over the last number of decades have tried to see what combinations work best, what orders work best. And the story with gastrointestinal oncology mostly is it seems like if you're going to give something on top of surgery, it's probably better to give it before rather than after. With radiation, we know that works better on tissues that are better oxygenated, so before surgery is done, and it alters the vasculature. And the anatomy is far more clear when it comes to us designing our radiation plans. Those are a couple of our reasons that we prefer that. Not only the studies also bear out that in general, side effects are less if you can give it before, and the outcomes are generally better too. And in the process of this mixing and matching of radiations of short to long durations with or without chemos, we've found that if you give certain sorts of cancers, certain combinations of treatments, when it comes time after they're all done to head to surgery, you realize for a meaningful proportion of patients, the tumor's no longer there. And so that's led us into this realm of non-operative management, which has become a very standard treatment option for many patients. But there are specifics to that. So radiotherapy regimens in general, you'll hear patients talking about short course treatments or long course treatments. And short course usually just means 5 treatments given on 5 consecutive working days. So 5 and you're done, and you don't get chemotherapy at the same time as that. A long course treatment is usually 5 to 6 weeks of daily weekday treatments with smaller amounts of radiation given every day. It's the same sort of treatment volume as in the short course, but the total dose in the end is higher. Usually we give both of those sorts of regimens and then wait 6 or 8 weeks before we do surgery. We do that to let the acute side effects calm down. Importantly, we also do it because it takes rectal cancers and colorectal cancers that many weeks to actually start to show the shrinkage that sometimes we need before surgery. Some cancers, like a lymphoma, you give it a little sniff of radiation, and a couple of days later, it's already half the size. That's not the case with rectal cancer, colorectal cancers. These are relatively radio-resistant tumors, and they need more dose and more time. Usually when we're talking about rectal cancer treatments, we don't just mean that tiny little, or sometimes larger, rectal cancer that patients will be shown sometimes at the time of endoscopy. We mean that for sure, the gross disease, but then also where the cancer might be growing for sure in lymph nodes outside of the bowel within the pelvis, and then where the cancer would like to go next if it could, into spaces along the sides of the pelvis or up the lymph node chains along the inside part of the sacrum or higher up into the abdomen in areas where it's not matter of fact just to remove it all at the time of surgery. So back to the algorithms, all these different treatment options for patients and trials that led to it. One of our nurse navigators and I years ago said, well, this is getting a little silly. We just need to get organized. And so let's make some flow charts. And so we did that, and we got a little paper pad, and then we realized that pad wasn't big enough. And so then we got out some craft paper from my kids, and then we realized the branches were still getting too big, and then they weren't just going up and down neatly like we expected them to. We realized that this patient could not only go this way, they could go that way and that way. And then sooner or later, we realized it wasn't going to work this way. And so, unfortunately, you can group treatment recommendations that seem reasonable for certain sorts of patients, but they are not mutually exclusive options. And so, I warn my residents when they start a rotation with me that if they don't feel exhausted at the end of a typical consultation with a rectal cancer patient, they've probably not done their job properly and gone through all of the potential options with them. So let's talk about neoadjuvant radiotherapy. This is the most common sort of treatment that we do. We do it because acutely, these tumors often need symptom control. They are bleeding, they are painful, and we need to stop that, not just with a view to improving outcomes later on, but just to make people feel better and keep things safe. Sometimes the surgeons will say that they need certain parts of the tumor reduced in size. They'll say, I would love to just go in and do this surgery, but the edge of it is touching up against these blood vessels or the ureter, and I need that pulled away so that I can get through there at the time of the surgery. And so the radiotherapy can do that. Sometimes they say, you know what, I don't need you to shrink it so that I can physically, mechanically get it out of the pelvis. But we're mindful that for a lot of these patients, the microscopic disease that they won't see when they resect and that we can't see at the time of scans, the microscopic disease that will lead to a recurrence 2 or 3 years later, that also needs to be addressed ideally at that time as well. And so sometimes we're treating it not to shrink, even though we say that that's what we're doing it to optimize local regional control in the long term above the local regional control that we think we could achieve with surgery alone. Do we improve survival with radiotherapy? Probably not when we add it to surgery. For most of these patients, the only trials that have convincingly shown that radiation plus surgery improves overall survival compared to surgery alone. That was done at the time when surgery was not what we would call adequate anymore. It was surgery that would sort of go in and tease out the rectum itself, but it wouldn't carefully try to also remove the fat and the lymph nodes around. So radiotherapy there that showed an improvement in overall survival was probably just making up for substandard surgery. Now we don't see that anymore because we're trying to stage people more accurately and surgical techniques are modern. But local regional control is still absolutely critical outcome when we talk about managing patients with rectal cancer. And it only takes 1 or 2 patients that recur in the pelvis to make that clear in your mind. So neoadjuvant radiotherapy as part of TNT, this is a terrible acronym. It sounds so violent. It stands for total neoadjuvant therapy. It's just one of the combinations of radiation and chemotherapy with varying orders and things like that when we give them all before surgery rather than giving some before and then some after. And so when we do this sort of TNT approach, hoping for non-operative management, we're hoping for all of the same outcomes as in the above grouping there, controlling symptoms, shrinking disease, controlling microscopic disease. But then also we have that dangling little potential outcome of not needing surgery ever. So we are often now using this as an option for patients with very low rectal cancers, ones that come close to the anal canal, where the surgeon says the type of surgery that would be necessary would be one that would also remove the anal canal, one that would leave a patient with a permanent ostomy. So in the hope of avoiding that, as long as we think the function of a spared anal canal would be reasonable, we're usually talking about this sort of a strategy. And it can be a long, many months long process. It would be 5 to 6 weeks of radiotherapy, about a month break, and then 3 months of chemotherapy coming every 2 or 3 weeks, followed by time to let that work, followed by reassessment. And so from the time that somebody meets me in clinic and we talk about this potential for avoiding surgery until the time when we know if they're going to be able to do that or not, it's about 6 months. And it's 6 months filled with lots of stress, lots of tests, lots of treatments, and lots of side effects and things. And so it can be hard at many times during that period to keep your spirits up, waiting for the payoff. So how do we pull all this off? How do we plan it, prepare it, and deliver it? I see somebody in clinic, and then we talk about simulation, which is the mapping scan, the technical information, the visual information that I need to plan the radiation, the pictures that I use to contour and target. There's a huge apparatus behind me in the clinic, physics and dosimetry and therapy staff that have to do with the technical aspects of things. And so more than one set of eyes of a radiation oncologist is set on every patient's treatment plan. There's a rigorous process of QA and peer review, far before we even get to the time when the treatments are given. And so this is what we used to do when we were planning or doing the mapping for radiation. We would plan these treatments based on plain x-rays. And you would learn that the rectum, say, lies at a certain position in relation to pelvic bones and the sacrum. And then you would set up standing beside the therapist who are taking these x-rays real time, and these bars would move. And then you would decide at the time with your patient lying on this table, this is an x-ray machine, but it's set up in the same sort of formation as an actual radiation treatment machine. And so we knew if we could move this x-ray scanner, this mapping scanner around them and have them comfortable and then see their tumor in a certain way at the time of planning, then we would be able to deliver the actual treatment beam in the other sort of machine that is set up in the same way. And so this isn't a pelvis, this is a chest. As you can see, the collarbones here, and these are the lungs. But what we would do is we would have in our little room behind the curtain, lead curtain, our scans that would tell us that the tumor is here and here, and then we would say, yes, no, make this bigger or smaller. Each of these is a centimeter. Here's an example of us treating a bone lesion. You can see the normal bone here, and then the area of metastases here. And so it was fairly crude, but it worked very well. And the type of radiation that would come from the treatment machine to the patient has not changed at all from this time. Just the way we plan and administer the treatments have changed. Now, what we do for most patients with rectal cancers and colorectal cancers is we do the mapping with a CT scanner. If patients say, oh, I don't like CT scanners, I don't like the narrow little hole, you can tell them that the hole that we have is bigger. It's because we need them to be able to move their arms and legs and things out at various angles to accommodate how the beams are going to come in. So sometimes that can help. Most of the time, patients getting treatment in the pelvis or the abdomen go in head first, but we can do it sometimes with them having feet first. So that's something you can ask the staff. If claustrophobia is a real problem, sedation is a problem, or an option, but you don't want to have to rely on that 25 or 30 times. So that they come in, there's a scheduled appointment. It's usually in the actual cancer center, not in the main hospital. And we position patients as they will need to be every day for their actual treatments. And so you will see on charts the word supine, that means lying on your back. So here's an example. This is one of our nurses. We've got her in a position that would be pretty common for a patient with colon cancer or rectal cancer getting treated like this. We put the hands folded here because the beams will be coming in like this to the pelvis. Sometimes they can go at the side. Rarely do we need to have them elevate the arms above the head, but if they do need to do that for whatever reason for a high-riding colon cancer, there are handles and grips and things. And so there's a lot of technical stuff that can be done. It's critical to make sure that patients are in a comfortable position at this time, not tensing and holding it just long enough to get the scan done, because if they're going to have to try and do that, 25 or 30 times, it's not going to work, especially when the side effects start. And we end up having to redo the scan. So the therapists that bring patients in and counsel them through this process are acutely aware of this. Prone position, sometimes we have them lying on their belly, and then there's a little cutout here where the abdomen fits in. We do that because we try to let the small intestine fall into a pouch here and away from where the beams are going down into the pelvis. We then set a coordinate system so that we can replicate the position that patients are in when they go to the actual treatment room later on. And all the coordinates in the mapping simulation suite are shared with that in the treatment room as well. To aid with that, we give them little tattoos. They are real. It's real ink, and they line up to where the laser lights come in on reproducible areas within their body. And so patients will sometimes ask, do these point to the cancer? Not necessarily. They're just at parts on their body that we can find day to day fairly quickly. And that's what they look like. It's just a tiny little freckle. It's a rite of passage for every therapist during the parts of their training. In the same way I had to put IVs and lines into my med school colleagues, they have to give each other tattoos so they know what it feels like. We can also do fancy things like capture how much internal organs are moving at the time. So it's not just important to have an idea of how patients are physically moving within the room themselves, but also nice to know how much their organs move on the inside. And so here's an exaggerated example of how the top of the liver here can move from this level all the way up to this level just with some changes in breathing. And if we were to be targeting a colon cancer high up by the liver, that's the sort of information that you'd want to be able to capture at the time of your simulation. And we use not just CT scans over here where the hips are white, but also MRI images as well. And so to orient you, this is the buttock, this is the bladder here in front, this is the rectum. These are lymph nodes around the rectum that are involved with the cancer, and you can see them with a greater degree of detail than you can just on the CT scan. So MRIs are becoming more and more involved. This is an example of our nurse again in the belly board. And so you can see this white outline here. This, oh, she would make me say this is not her belly. This is not her adipose tissue here. But you can see the small intestine is falling down away from the pelvis. And we have them fill up their bladder as best they can to push that small intestine over the ledge and away from where the beams will be coming to the rectal cancer there. I take those images and then I go and I draw on a screen outlines of where the cancer are and then set an extra margin to allow for the fact that the cancer might move inside the patient day to day. This is an example of what those lines look like for a patient with rectal cancer. So I outline where the actual gross tumor is. I outline areas where I'm concerned that it might be spreading to lymph nodes, and then I put an extra margin on that to account for movement of the rectum, the bladder, and then the patient as well. And that's just a view of it from the sagittal image that way. And then what we do is we place beams to cover those areas. And so this is a very simple example of that, with one beam coming from each side and one from the back. As they overlap, as you'd expect, you get sort of a square-shaped distribution where the dose is greater. Read this like a topographical map. As the colors come in, the doses go up in the same way elevations do on a map, compared to a treatment where we use highly conformal techniques with many, many beams coming from all angles. That yellow area where the higher dose is, we are able to conform it and make it miss parts of the body that we don't want to treat with high dose, like this little loop of small bowel here. So these are some of the advancements that we've made with better imaging. And this is just an example of how the dose comes in again. When patients come for their treatment, most of the machines look kind of the same, or some of them will have a big door that they go through. Lots of other centers will have what they call a maze, and so it's a circuitous little pathway. And then there's a treatment machine with a couch and a coordinate system that's set up very similar to how things would have looked at the time of the simulation scan. We call it a linear accelerator. This whole thing moves and it beeps and it whirls and stuff, and it seems a little bit overwhelming on the first day, but some patients say their biggest challenge after that is staying awake. You will see treatments referred to as image guided. All that means is that we take some pictures to help verify where the patients are in the room before turning the beam on. And what we will do is we will have a split screen with scans taken from the time of our mapping scan and scans taken at the time of the patient lying there in real time. And if there is a mismatch in where patients are lining up within the room, then a little joystick is moved by the therapist who control the couch. The couch will move. The patients will then get aligned properly into their ideal patient position before the beam goes on. And one of the newest things that has come into play for patients with rectal cancer is called an MR LINAC. And so every day with this sort of machine, and there are just a few within the country, patients will go in, a real-time MRI scan is taken, and I will sit there and I will draw on the day, every day, an outline of where the cancer is at the time. So conforming not just, you know, every 5 or 6 weeks, but every day to the realities of what the anatomy is. And so with rectal cancer, it's going to be a matter of finding which patients actually benefit from this degree of precision day to day, because it is a very resource intense operation, and it's a lot for patients to sit and have an MRI every day. This is just a slide to say that despite me being a radiation oncologist, I'm not allowed to actually press the treatment button. The therapists do that, and they get mad if you even joke about it. Okay, side effects. I think I just got a couple more minutes. Sorry, I think I'm a little bit over. Side effects, well, it depends. It's like real estate. It's all about location. So um, if you have a very symptomatic rectal cancer beforehand, the chances are that you will flare even more on treatment. We add little bits of inflammation every day. The location of the rectal cancer will change. Lower cancers down by the anal canal are more symptomatic than those higher up on average. If you've had surgery before, if you've had a really aggressive endoscopic piecemeal resection of a rectal cancer, all of those things have already induced a lot of inflammation in the pelvis, and radiotherapy is going to make it more challenging. Comorbidities, age, performance status, the usual sorts of things. Giving chemo at the same time, which we often do during long course, also increases the toxicity meaningfully. And then the total dose that we give and how big that treatment volume is. With rectum, what patients, most of them will find is more urgent and frequent bowel movements. If they're getting the 5 treatment course, it's usually not until the week after the radiation treatments are done that they're really starting to notice that. For the long course, it's usually in the 3rd or the 4th week where they're really starting to notice a lot more downward pressure within the pelvis, needing to go to the bathroom, feeling that a huge bowel movement is coming, rushing to the bathroom, sitting down, and then just looking at a little bit of gas or a little bit of mucus and saying, well, that can't be everything. And so then they push and they push, and that just makes more hemorrhoids and things like that. Yeah. But nothing more. Letting us know, try, but there are weeks of patients being very uncomfortable. The bladder sits right in front of the rectum, so it gets inflamed and it can feel like a bladder infection, which is not new to women. Men start freaking out on average because they've never had a bladder infection. They have no idea what's going on. And so it can be trouble, especially if the prostate is also swelling and it's hard to get the urine out at the same time. Vaginal irritation is bothersome, especially for the lower cancers where the higher boost doses are affecting the tissues there, especially if the rectal cancer is invading the posterior muscular wall of the vagina. Bones and nerves, for sure. I hear about twinges. I hear about electric shocks and vibrations and things like that. These aren't doses that typically give any permanent damage compared to some of the chemotherapies, but I hear about it often within the first week of long courses and then not so much afterwards. The skin can be very tender, it can get very red, it can be like peeling. I tell some of the patients, especially those with the low rectal cancers where we need to treat the anal canal and the lymph nodes in the front of the legs, it's going to be the worst sort of sunburn you could ever have imagined. It will peel off, it'll be achy. You're going to spend weeks at home where you just come to the cancer center, you go back home, you get on a very comfortable, loose-fitting set of clothes, and then you just sort of try to keep the area as comfortable and as clean and as dry as possible. It does get better reliably at about the 3-week mark following treatment. All the new cells start to come from the bottom and there's a rapid improvement, but it is a very uncomfortable time for many patients, especially with the low cancers. And then overall, yeah, you get tired. And women will notice, even on the time of treatment, some hormonal changes if they're premenopausal. Just a couple last slides. Apologies on colon cancer itself. We don't use it that much for curative treatment. The exception can be if you've got a very large cancer that has become adherent to something that is anatomically stable, like the abdominal wall, like the liver, or something like that. We can give weeks of treatment to those colon cancers because it will be easier for us to target it reliably day to day. More commonly, we will give it in the post-operative setting if the surgeons have tried to remove it, but there's a positive margin and concern that there might be a little bit left behind. Hopefully they've left some clips. Often they'll call me from the OR saying they're going to put in a spacer to move the rest of the small intestine away from where my beams will be going later at the time. We give a lot of radiotherapy for palliation of symptoms for colon cancers. A huge proportion of my patient population in the last number of years has become elderly patients with a very localized and early stage cancer, but we can't do surgery or anything aggressive because of dementia or frailty or things like that. And so they need some treatment. And although palliative intent, I do treat them aggressively because like they're not going to have an easy quote unquote way out just because they've been diagnosed with a colon cancer, which is what a lot of patients will think is coming when they talk to me in consultation. And I'll say, well, yeah, you've got a cancer, but it doesn't mean you're going to die immediately. And if we don't try something, and something relatively aggressive for the colon cancer with radiation, there's going to be more than enough time for you to still be living and living uncomfortably due to symptoms from the progressing cancer. So I think I do surprise patients with how much treatment I talk about when it comes to that sort of a patient phenotype. And so here's an example: patient with dementia who had a cancer in the transverse colon, which is notoriously mobile. So we had an endoscopist put in some radio-opaque little seeds, platinum fiducia markers, because this tumor will move all over the place day to day, but we can see the seeds when we do the scans day to day, and then we can move this sort of cloud of radiation here or here or here, depending on where it is. And so this is how we're using the newer technologies to treat patient populations that we couldn't previously. The MR linear accelerator is going to be key in this, and we're starting some trials here in Ottawa, hopefully within the next year for precisely that. So I am sorry I went over, but please send me any questions you'd like afterwards. Thank you.
Thank you so much, Dr. Dennis. And no, you were actually ahead of time. It was
Oh,
perfect. So
okay.
it went great. Thank you so much for both an engaging and detailed session. We appreciate it very much. To our silent viewers, again, a reminder to head back to the lobby to join the next session, which will be immediately following the question period over the next, I guess it would be about 28 minutes or so. So we will be, yeah, again, back right after the question period. To our coaches, if you could please enter the backstage, and then we can get engaging in those questions now. See everybody soon.